About what we've been up to for the last 2 years. It's a real privilege to have with us today Professor Jason Leitch. He's someone I always look forward to listening to at conferences, so I think we're in for a treat. Jason started out as a dentist and an oral surgeon, and for almost the last decade now, I believe, has been leading the quality improvement work across the whole country of Scotland. So Jason's going to talk to us today about how to sustain large-scale change, which is a really important factor for us. And during the talk that Jason's giving, if you have any questions that crop up in your mind, use your phone to pose the question on Slido, and James will be putting those questions to Jason in 15 minutes' time. So, over to Jason.
Thank you, Amar. Morning, everybody. Morning. So, there's something you should know. My mother is watching. She's on her sofa, in her living room, retired, feet up, usually watches the tennis, has chosen to watch the live stream of this conference. So, sit up nice and straight, no swearing. The problem is I can't tell any lies, so I'm slightly restricted in what I can tell you. So I can't, no, I can. And she says she doesn't care where West Ham end up in the league. That's her most important contribution so far. And my sister's a social worker. She teaches social work in a further education college. She is also watching. I don't know why, because she should be working. I think she's just keeping my mother company. Thank you very much for having me. It really is a privilege to be here. There is you may not know this, but there is a kind of hierarchy and league table of quality improvement organizations around the world. And we kind of thought the league table was full. And you've come from absolutely nowhere. You really have come from nowhere. So we've got Jönköping and Kaiser, and Scotland likes to think it's in there, and the Mayo Clinic, and Virginia Mason, and the Danish safety program. And then suddenly people started to talk about East London. I thought, that can't be right. That's in England. They don't do QI. That's this big reform thing happens every 2 years. They sack all their chief executives everywhere in that country. Surely they're not doing good work. So I waited. I hoped you would disappear. And then you didn't. And some Scottish people came to visit you. Some of those Scottish people are here again today, in fact, to visit you again. And they forced me to come see you. About a year ago, maybe 9 months ago, and I visited for a day, and it was real. So I was very, very impressed. It is genuinely real. And I fear that you in some ways are overtaking us, which I don't like. So we're going to try and catch up a little bit. My brief this morning was to kind of give you a very short TED Talk style, so we've not got much time, so I'm going to go quite quickly, but it was to discuss sustainability. So now that you've done this for 2 years, now that you've got 151 projects active, I'm quite sure if you added up the ones that you've done and have finished, it's hundreds now, and many of you involved in those. How can you keep it going? So let me first of all give you some examples from Scotland, and then 3 lessons that I think you could perhaps take from some of the work in Scotland. But let me start here. This is Adam. Adam is a newborn. You may have spotted that. 3 days after he was born, Mum and he went home happily, healthily, no problem. She had a section. She felt unwell on the Tuesday following the birth, which was about 3 days post-op, and deteriorated really fast. She ended up back in the acute sector in Edinburgh, where they live, the second best city in Scotland. And she was really struggling, close to death. It's a long story, but she wakes up in intensive care, and she remembers through a kind of hallucinogenic fever a staff nurse at the bottom of her bed saying out loud, yes, sepsis 6, 36 minutes. And she, the mum, is one of the team in Scotland who found the evidence, designed the bundle for the sepsis 6, would you believe? And the sepsis 6, for those of you who don't know, is about 6 things that you have to do reliably within an hour of the diagnosis of sepsis. This mum had sepsis and would have died, and survived. She survived as a direct result of the broad work in quality improvement in Scotland. So I want you to remember when I show you data, when I show you numbers, when we think about theory, and as your day progresses, I want you to remember that behind every number, behind every dot on each graph is Adam, is a kid or an adult or a user who's in this room, perhaps, who's been suffered less harmed as a direct result of your work. So this is the country we're discussing. You may have come across it. This is what it looks like from space. We've actually made it tartan. We've painted each of the health boards a different tartan so we can tell them apart. Now, here's the thing. We have integrated healthcare. Are you familiar with this concept? It's where one organization would be responsible for all of the healthcare. So we have no chief executives of hospitals. I couldn't take you to a hospital leader. We don't have such a thing. We have board population health leads who do the hospitals, the primary care, the mental health, the public health, all in the one place. You want to move? You're very welcome. We could really do with some radiologists. If there's pediatricians we're a bit short of, I think we could probably find positions for most of you. Chairs of boards I could do with. So this is the size of the institution. We've got about 5.5 million people. We've got about nearly £13 billion now to spend on that healthcare. 14 delivery systems, 8 systems that we only do once, so 1 ambulance service, 1 education service, 1 improvement service. And then we're moving on the 1st of April to integrate social care. And that's a whole other lecture. You'll have to bring me back if you want to hear more about that integration move. Let me show you what nationally has happened around the probably 8-year journey we've been on around using quality improvement. Exactly the same techniques that you've learned. We've been in partnership with IHI for those 8 years. We've now branched out a lot more on our own. We use IHI much more sparingly, still use them, and we use you, and we use Cincinnati Children's. We use the great institutions, high-performing healthcare systems of the world. This is sepsis mortality, which is down 21% across the whole country. This is ventilator-associated pneumonia in a microsystem, just inside 1 intensive care unit in the middle of Glasgow. That's a 60-day period, those of you who have spotted it, with no pneumonias. That's unthinkable 2 years ago. It's imaginary 8 years ago. That's a 48% reduction in ventilator pneumonias in this intensive care unit, in that big pediatric intensive care unit. This is our stillbirth rate. This is brand new. Not many people have seen this. We've now moved from our acute-based safety program into a huge all healthcare and even outside healthcare work in safety and harm. And this is Scotland's stillbirth rate, which has fallen 15% in the last 3 years. Principally around fetal movement education for mums. Not only that, we now review every stillbirth in a multidisciplinary team, sometime with the mums present. And it has radically changed the way we do stillbirth and infant mortality across the whole country. I know I keep saying this, but this is whole country data, remember. This is not a single unit, a single board. So the safety program began in acute hospitals. That's where we chose to start. It's where IHI had most of its experience. It's where we had most of our teams, and that's what we did. Now we're in mental health. That's why we've had the connection with you, and it's some of the mental health people are here. Alison's also here, who helps run the acute adult program. We've got maternity and children's and primary care, and that primary care one is now in most of the parts of primary care. I was originally a dentist, so you won't be surprised to know I've been fighting for 8 years to get a dental safety program, and finally we started it last week. So we have, we think, the first strategically placed dental safety program in the world. We have community pharmacy, general medical services, as you would recognize, and also community nursing. So what have we learned? Well, we've learned a huge amount. We've failed, we've succeeded, we've done everything in between. So let me give you 3 lessons that I think you need for sustainability. I think you need, unfortunately, to pay attention to politics. So we couldn't have done what we did if we hadn't used the politicians. Now, I don't know what your equivalent of that is in your world. It may be executive, non-executive leadership. It might be local councillors. It might be national politicians. You will have MPs for this area. They have enormous soft and hard power that you can get into. And we started to do that. We wrote policy documents inside the government. Now, if you told me when I was an oral surgeon that I would spend my life writing policy documents, I'd have thought you were crazy. And I still don't think they're that important, but you need them. They are necessary but not sufficient. So you need to have a thing that says what you're going to do, and this is Scotland's quality strategy. 2010, It says, this is what we're going to do. There's a driver diagram inside this policy document. Can you imagine such a thing? A government policy document with a driver diagram inside it. It was revolutionary. It actually had numerical aims inside it. The civil servants struggled a little with a numerical aim, but it said what we were going to do. And the First Minister of the country, who was then the Cabinet Secretary for Health and Wellbeing, and my boss, she's still at some level as my boss, she's just risen a level, she stood up in the Parliament and said, 20% of Scotland's patients are harmed by the care they receive, and here's what we're going to do about it. So she took political leadership, and then she made me tell her every week how we were getting on. Because that's what they do. That's what, if you walk in their shoes, that's what they do. But I don't think Scotland would have achieved what it's achieved without that level of political leadership. I don't know what your equivalent of that is, but I think you need to pay attention to it. It's not everybody's job, but some people in this room need to pay attention to that job. The second thing you need to create, and I think we could learn from you, actually, is you need to create, it's jargon, but you need to create a learning system. And you've just heard from James and from Amar how you've tried to do that, how you've created capacity, how you've built people up, how you've created an online presence that people around the world are now using. And this is one example of what a learning system looks like. There's a lecture in each of these bubbles, but this is by Tom Nolan's work, who's one of IHI's helpers, one of their big intellectual brains. And these are the things he says you need inside a learning system. And you might want to test your work against these circles. So, are you having periodic review by executive leaders or peers? Are you segmenting the population in such a way that you can test and then move to scale? Are you testing those changes? You get the idea. So create a learning system in which the work can happen. That will be at the microsystem level, of course, but it will also be at the macrosystem level, where your board is meeting to be a learning system. So we've tried to do that in our capacity building approach. You won't be surprised it looks quite similar to yours. So we've got a Scottish Improvement Leaders Programme where we train 30 improvement leaders at a time, a bit like the Improvement Advisor course, those of you who are familiar with it. We bring Danes and Norwegians onto it to pay for the Scots. We're not stupid. So we have about half a dozen places that pay for the other 30. And the Norwegians have got lots of money. They've got oil. We've got a quality improvement. So have we. That's a whole other argument. There's a whole thing about oil that I shouldn't do as a civil servant. We have a quality improvement fellowship, principally senior clinicians, mid-career clinicians, not only, but that's also teaching leadership for improvement. And then we have a bit like your I can't remember what you called it, but the shorter one, the QI Light one. That's what? Pocket QI. It's a much neater phrase than QI Light. That's our version of that. And then we have board leadership, which we're about to reinvigorate again across the country. We have nearly 350 board members across that whole infrastructure. And some of them know what a run chart is, and some of them don't. So we need to increase that level of education. And then we've got thousands now who have been on our collaboratives, who have been inside the actual work where that key thing happens. And then we finish with lesson number 3. And I think you're good at this. It was your first point in Amar and James's introduction. It was about telling the story. It was about selling. Now, people don't like that. People think it's all PR and fluff. It's not PR and fluff. It is about joy. It's about building up the staff. It's about telling the message both to users, citizens, staff, other politicians, other leaders. And we've got quite good at that. We've got quite good at embracing the difficulty that the media presents us, but we do it. It's frustrating, it's hard, it's sometimes at midnight, but you've got to try and do that as much as you can. So this is the BBC website talking about mortality rates. We've had to explain HSMR to journalists. That's not an easy lesson to teach journalists. It's not an easy lesson to teach mortality experts, frankly. This is one of the Scottish national papers talking about morning huddles. So we took the journalists to the ETM huddle in one of our hospitals, talked about it. They meet the staff, they walk the floor, they meet people who are enthusiastic about safety and quality. I don't always have fireworks behind me when I present, and I didn't choose for this image to be in there, but this is about selling the message internationally, so we tell the story. So we're pleased when East London wants us to come and tell the Scottish story. We're pleased when we go to America and we tell the Scottish story, or recently in East Africa where we got the opportunity to tell the Scottish story. So we want to tell it because it builds up our people and we learn from others. These are our massive collaboratives. So we have collaboratives with 900, 1,000 people in them, and we have collaboratives with 30 people in them. We're not as good as we should be at the scientific communication, at the publication of our work, and we need to have a real good hard look about how we do that. I think you guys could probably get better at that too. You've got enormous work, so have we, and we don't publish it in the mainstream literature for science, and we really should. And then just like you, we spend a lot of time submitting for awards. The guy in the middle there with the kilt on, can you just see him? That's what we all wear every day, you'll know that. That guy's Kevin Rooney, who, along with Alison, who's here, has led the sepsis work across Scotland. And Kevin was last year's NHS Scotland Doctor of the Year. I didn't choose him, I promise. There was an independent panel who chose him as Scotland's Doctor of the Year. But that gets us media presence, it gets us to talk about the safety programme. It gets us that press. So there, I could have given you 10 lessons, but in the time allowed, they're my 3. Pay attention to the politics. Create at all costs a learning system and be specific about it. Do not let it happen by accident. And communicate, communicate, and communicate. I don't think you can overinvest. The communications people will love this. I don't think you can overinvest in the communications department. I really don't. I think you have to get really, really good at it. And I want you to, as we finish, remember Adam. And that's why you're doing these 3 things. Thank you for listening.
Thank you so much, Jason. Absolutely fantastic presentation. Such parallels between Scotland and East London. That's what it's all about. We've had some very interesting questions.
Are they from my mother, no?
Oh, I didn't check. I did look. So we've got one very good one. How do you ensure that the latest crisis doesn't take attention away from QI?
So the leadership, it's a leadership, 2 things. It's a leadership job to separate crisis from day-to-day work. So leaders can't avoid the crisis. You can't just hope it'll go away. So I spend a lot of my time in that acute moment. I'm quite sure there are people in this room who do whatever the latest target is, whatever the latest big serious harm was, the serious adverse event. But leaders have to, at some level, protect the front line from those crises. The other thing is that if you don't think QI is the answer to them as well, you've misunderstood. So we have a hospital just now struggling with the 4-hour wait. We can have a whole discussion about the 4-hour wait if you like, whether it's right or wrong. It doesn't matter. It's a political decision. We're having it. So the chief executive of that health board has asked his QI teams to help him with the 4-hour wait. Now, initially, some of them are thinking, we do pressure ulcers. We don't do the 4-hour wait. And they came to me for some advice, and I said, well, if you can't solve this, you got no currency. You can't. He's not going to ask you to do anything else. So invest in it. Fix his crisis for him. And they did. Of course they did. So they went in with flow technology, with PDSAs, with norm, but they did it fast and hard, and it worked. So you have to use the same methods, otherwise nobody will take you seriously.
Great. And another one, which I guess is a problem for all of us, about austerity. How can we maintain quality during this period of austerity?
So I only know my system. So there's 13 billion quid. There's money. There isn't new money, but if you walk through your system with proper fresh eyes, you'll see waste everywhere. In every appointment, in every transaction, in your way of working, you'll see it. The trick is for the leadership again to be able to take that waste out and reuse it. So to try and use it for good, to try and use it for QI, to try and use it for other people. If this isn't the answer, I don't know what is. I don't know where the performance management and yelling at people, does that work for you? It hasn't worked so far. It works for a week, and then it disappears again. And I understand it's tough. I understand that when staff are short or resources are hard, it feels more difficult. There's a famous story in Sweden where Jönköping, who you've heard me mention a few times, probably the highest quality healthcare system in Europe, a relatively small county council in Sweden, where Joran, who's the head of quality there, was called to the health minister's office. And the health minister had noticed that they had the best outcomes in Sweden. And he said, I want to do two things. I want to put you in charge of healthcare across the whole country, and I want to give you a 10% increase in your budget for Jönköping. And he said, I definitely don't want to be in charge of healthcare for the country, so you can forget that. And he said, I don't want the 10% for Jönköping, but I need you not to tell them you offered me it. Because he thought there was something in the stress and the platform that the constrained resource gave him. And he didn't want money to be the solution. That's perhaps easier in Sweden than it is here. Slightly more money than we've got. Not huge amounts, but I think there's something in the efficiency drive that we are the answer to, not the problem.
Can we just give Jason an absolute round of applause? It's been fantastic.